Afternoon, good morning, good evening, colleagues, to this webinar on prevention self-assessment tools that is organized by the South-to-South Learning Network in collaboration with the Global HIV Prevention Coalition and several other partners. And we're glad that you could all join us today. So the prevention self-assessment tools are part of a broader suite of tools that we have in the context of the Global Prevention Coalition and the South-to-South Learning Network. And we have for today an agenda to actually introduce them in this broader context. So we'll have an introduction of the PSAT tool by my colleague Heather Marie Schmidt from UNAIDS WHO as part of the Global Prevention Coalition Secretariat. We have a presentation on the results of prevention self-assessment tools in 15 SSLN countries from Camogelo. We have a panel discussion then on the use of the PSAT and the case studies facilitated by Celestine, where we hear from different countries, including Nigeria, Uganda, and Zimbabwe. And finally, again, reflections with country perspectives from South Sudan and the Republic of Congo. To put this into perspective, of course, we have different tools available in the AIDS response, and we have a high-level tool, which is the scorecard of the Global Prevention Coalition, and we have more specific, really detailed granular assessment tools, and these are the prevention self-assessment tools that we are talking about today. Maybe colleagues, should we briefly go to the, before maybe saying a few more sentences on the tools, should we briefly go to the logistics announcements? I don't know if you want to bring those up. Yeah, so we have, as part of this webinar, as you may be familiar with from previous occasions, interpretation available, and you can click on the interpretation icon for English, French, and Portuguese, and then also a Q&A box for asking the questions, yeah, also contribute to other people's questions and comments. And we'll have a survey actually towards the end of this webinar on some specific questions as well. Going back to the scope, so the program self-assessment tools are really the most relevant tool for you at country level when you want to get a very detailed and granular understanding of one core component of the HIV prevention response, and as mentioned, function in a broader context of tools that we have available. This process of self-reflection is actually something that we feel is particularly important as a starting point, not only for planning, but for understanding actually programmatic gaps in the how to implement prevention programs, gaps in the systems, and gaps that may be often more qualitative and not visible in the bigger picture data that we have in our global AIDS monitoring, in our HIV estimates, and in our programmatic coverage and outcome measurement. So I think without further ado, I'll end here with this brief introduction. Of course, this comes at the critical moment for HIV prevention, where we are progressing, where we have good examples for HIV prevention in the region, in the Africa region, but we also still have, in the majority of countries, steps to go to actually achieve our overall HIV incidence reduction targets, and also many of the prevention outcome targets. And maybe one last observation from this, from our global data and reporting, there's actually not a single country that has achieved high outcomes in all 5 pillars of prevention. And therefore, actually, although we have good examples in each of the pillars of prevention, it's actually a tool that's relevant for all countries to choose really those areas where you see still gaps and dig deeper in understanding the underlying programmatics and systems issues. But with that, I'll end here with this broad scene setting and hand over to my colleague, Hedda Marie Schmidt, who will introduce the PSAT tool. So over to you, Hedda Marie.
Thank you so much, Clemens, and good afternoon, good evening, and good morning, depending on where you are around the globe. It's a real pleasure to be here on behalf of the Global Prevention Coalition Secretariat and SSLN to speak about the PSAT. So next slide, please. Next slide. Fantastic. So as Clemens briefly mentioned, the PSATs, or the Prevention Self-Assessment Tools, sit within an ecosystem of analytical tools for national prevention reviews. And so many of you may be familiar with the scorecards or the Global HIV Prevention Coalition scorecards that Clemens mentioned. These provide that overview or synthesis available to understand gaps towards global targets. As we go down the levels of that analysis, we have other types of tools, things like the roadmap surveys, the GAM, other surveys. At the next level, we have things that estimate prevention needs. So key population size estimates, for example, condoms needs estimates. And then next slide, please. At that granular program analysis level, we have the prevention self-assessment tools, and these sit across the 5 pillars of prevention: key populations, adolescent girls and young women, boys and men or VMMC, condoms, and ARV-based prevention or PrEP. Next slide, please. So taking a step back, what are the PSATs? So they are a standardized tool that reflects global best practices in HIV prevention. And this was a recognized need, particularly to support cross-country analysis as well as in-country reflection. Now, Clemens mentioned and really provided a really nice introduction about the value of PSATs with self-reflection, and we're going to hear much more about that during today's case studies and examples. And so they have this value around self-reflection. What's really critical here is that they're not used to evaluate, per se, global HIV programs. They can be used to monitor progress towards comprehensive prevention programming, and they can help identify, articulate, and advocate for technical assistance needs, resource needs, capacity development needs, and additional investment needs. So really important and valuable tools. They're used, the way that they're used is by outlining a component of a comprehensive program, and I'll go into this in more detail later. But in terms across 5 main domains. And in terms of operating them in country, you'll see that it's anticipated that a small group of informed individuals, so for example, a national technical working group, can complete the tool and then constructively discuss it. And of course, I've mentioned that the PSATs sit across the 5 prevention pillars. Next slide, please. I won't go into the detail about the process for creating the PSATs, but what I want to emphasize by showing this slide is that it was a rigorous process, and the updates have been made as global guidance, for example, advances, and as there are changes in needs. So, for example, after the completion of the full PSATs, light versions have been used, which can be used have been created, which can be used after baseline. And there is a continuing process of update as things change. Next slide, please. So in terms of the specific objectives, PSATs support country programs and partners to recognize characteristics of global best practice, including, for example, WHO guidelines, for each component of a high-performing program. Understand how they perform against, so the country performs against each programmatic component, benchmarking the country's performance against prior performance and program maturity. So this has an assumption around repeating the assessments, because indeed these don't have to be one and done, and you get a lot of value from repeating them periodically. Prioritizing components of country programs on what should be the focus, as well as what is being done well and what should be documented, replicated, and scaled. I mentioned the identification around needs for technical assistance, capacity development, etc. And this is particularly important where some of the components don't score very well or score very highly. Comparing relative performance across countries and benchmarks within a region, and advocating for interventions or resources. Next slide. So looking at specifically at that structure and components. Next slide. Each piece, the components of the PSATs work together. So they're structured according to 3 domains: program management, program implementation, and program outcomes. And a number of functions sit under each domain. Each function in turn is made up of a set of elements or activities and services that are provided by the program. Now, each of the PSATs will have a slightly different component, and many of you on this call have actually used or been involved in the use of at least one of the PSATs before. Next slide. The scoring for the PSATs is then, it goes through an automated process within the Excel file. And so participants at the country working group, or TWG, can evaluate each criterion, so the function or element, against what is performing well or what is not so performing well. And so choose that score to accurately reflect the country's HIV prevention program. The scoring is reinforcing that the scoring is meant to monitor progress. It's not about a pass or fail. It's about what's working well, what is maybe working okay but could be improved, and what really could be improved. And this is really very much based on that consensus between different stakeholder groups. Next slide, please. And at a glance, this is what that looks like within the tool. And this is just an example that's across one of the domains, program management, and you can see the different elements, the criteria, the scoring, and then within the tool, there is an opportunity to be able to comment so that you can understand why the group who was working towards and completing this PSAT gave a particular score, and perhaps what they believe was missing or what was working very well. Next slide, please. And so I mentioned as well that it's not only about self-assessment or self-reflection, it's about comparing progress over time within a country, and to an extent between prevention pillars. Often countries will, there may be particular prevention pillars that are doing really well and others that aren't doing quite as well. Some pillars are comparatively much more new. So PrEP, for example, is much newer in some countries. But the other advantage of these is that you can compare across countries. So this is an example from of PrEP, and it's possible really to compare against peer countries. So looking at how different countries perceive their relative strengths and weaknesses, and this can be a really powerful tool for dialogues or starting dialogues and cross-country learning between countries. So a country who's doing particularly well in certain aspects may be inspiring for your country to talk to. Or, and so it can really facilitate those dialogues. Next slide. Now, PSATs have been completed in at least 15 countries. Most of those countries, or indeed all of those countries, have been located in continental Africa. And however, there are many more countries within Africa, but also within other regions that would benefit from being able to use these tools. So we're really eager to be able to expand the use beyond the countries that are currently using it. And this is part of why we're together today, to hear about some of the really inspiring examples of how these tools have been super useful. And so this is my final slide, and it's really just about considering what the future might entail. So considerations for now and into the future. So for countries, and particularly countries who are new to PSATs, selecting the priority or mix of PSATs relevant to your country and context. You do not have to do every PSAT. And starting with the one that's maybe most relevant to whatever priority is within your program, whether it's key populations or adolescent girls and young women programming, or perhaps your country is going through massive prep scale up. This can be an incredible tool and a nice entry point into this. And we've seen in several countries that subnational PSATs are becoming more used and are really helpful where there has been devolution of the health system and health system responsibility, that these can be incredibly useful tools at a subnational level. A reminder that the process is as important as the tool, and having the right people in the room, the right buy-in are important, not just to completing the tool, but also then to taking the results of the tool forward and making changes, making program adjustments, making investments. There is not just one right way to use the PSATs, and we're going to hear about so many examples of this today. I mentioned light versions that have been introduced, and they are being used they're being used for follow-up assessments. And of course, there is planning for the inclusion of more options within these PSATs. And SSLN, we are working with the GPC, with SSLN, for example, around including PEP. So these PSATs are all available from both the UNAIDS GPC website as well as from the SSLN website as well. And I will leave it there and hand over to, I think, Clemens to introduce the next speaker.
Thank you so much, Helen Marie, for this great overview. And colleagues, you saw, just to repeat or emphasize, the PSAT is really an open source tool available and accessible through Global Prevention Coalition and SSLN web pages. So just putting the letters PSAT and GPC or SSLN into Google takes you directly to the web pages where you can find additional material. So with that, I think we want to move into practice now based on this great overview and understand what are actually the results of PSAT exercises in 15 countries which have used those tools most extensively. Of course, they have in part been used also by some other countries for specific purposes, but 15 countries have really done, with the support of the SSLN, extensive work that Camogelo Nuno from SSLN will introduce now for us. So over to you, Camogelo.
Thank you so much, Clemens. Good afternoon or good morning, depending on where you are in the world today. I wanted to talk a bit about the results of the PSATs across the 15 SSLN countries. And following on from what Heather Marie just shared with us, I wanted to just share an overview of these 15 countries. These are countries who are part of the South to South Learning Network, but I also want to speak about what insights can be gained from some of these countries who've completed the PSATs. So first, we're looking at just the overview of the PSATs that have been completed. So you'll see that across the board, a lot of the countries have done at least 4 out of the 5 pillars of the PSATs. And what you're seeing in the teal color are the baseline PSATs, but over and above that, the light version, which is a reassessment, a rapid reassessment, which is much shorter, has also been done in some of the countries. So about 2 years later, they were able to reassess and monitor their progress, having since completed the baseline PSAT. And what I wanted to bring out today with regards to the PSAT is that there are 3 value adds from completing this tool. One is that it unites stakeholders. So the PSAT brings a diverse group of stakeholders together. So we have people from government, from civil society, we have donors, we have implementers, all coming together to complete this assessment. It's also able to be a mirror for national programs. So these country teams, as they sit and complete this, they're able to have a clear reflection of the country's HIV prevention strengths and the areas for further development. And also it builds bridges. So PSATs foster this collaboration and dialogue, but also creates a sense of shared ownership amongst this group. So I wanted to look at an example of the KP pillar and just shedding some light again on this diverse group of stakeholders. So within the SSLN, we have a group of country champions, and country champions are a group of stakeholders that we bring together to complete this tool. So these are about 6 to 8 people per country, per pillar. And so having a look at this example alone, you can see the diversity in this KP pillar group specifically. So you can see about 22% of the country champions are from community networks, 20% are from development partners, 18% are implementing partners. And then looking at the government, we have the National AIDS Council being 18%, Ministry of Health being 15%. And then there's 4% of other government representatives, and perhaps maybe these are ministries outside of health. And then groups that fall outside of these scopes that I just mentioned, there's about 3% of those. So again, just highlighting that we have quite a diverse group of people coming together, and perhaps maybe for the first time, to complete this tool. So now I want to look at the insights from the PSAT findings. So Heather Marie mentioned that you're scoring yourselves, but what can we gain from some of these scores that these 15 countries have shared with us? So within the SSLN, we're able to do a cross-country analysis of PSATs. And just to shed light on this, I wanted to focus on the example of the sex workers PSAT. So within the KP pillar, we have the sex workers PSAT, and this is just an overview of these 15 countries that have completed it. And what I wanted to bring to your attention today is that having a look at these countries, you can see there's still a bit of room for growth. So looking at the overall score, so out of 5, there was it was 3.5, the average of the sex worker pillar. So countries self-assessed themselves to be doing about 3.1 out of 5. So that's relatively okay, but there's room for growth. And then there's some countries that have shown that they are doing quite well. So they are strong countries in terms of program management and implementation for sex worker population. So those are Eswatini and Kenya, and they have 4 and above for their management and implementation. But with this variation in the scores, we have this opportunity where the countries who have identified themselves that they have these areas where they would like to learn more, but then there's these other countries who have identified their areas of strength. So there's this opportunity to pair these countries and share these learnings across these countries. And so next, I wanted to just have a deeper dive into these. So what does it mean when you have a look at the program management and the program implementation and the program outcomes? So looking under program management, countries are assessing their leadership and coordination, their policy and regulations, and their financing. So this graph shows the cross-country analysis. So we've kind of overlaid all the country scores, and we're able to then have a quick glance at which country is doing particularly well at an aspect and which country has shown that they are having challenges at a certain aspect. But overall, having a look at this, some key takeaways that I want to pull out is that there is a solid foundation, but there's also a coordination gap. So accountability and strategies seem to be strong, but some countries have indicated stakeholder coordination is something that they're still struggling with, and TWGs are needed to strengthen this. We also can see that there is a need for enabling policies. So policies exist, but they must actively support sex worker environments. And that's what we're seeing from the scores, especially when trying to reach perhaps young women who sell sex. And then the last thing is looking at financing. There are quite low scores there. And so we can see that the underfunding remains critical, and improved budgeting, cost analysis, and advocacy are essential to try and secure resources. Next, we can have a look at the program implementation, again, having a deeper dive into what countries are actually assessing when they look at this. So having a look, there's quite a few functions under implementation. We have implementation arrangement, we have targeting and planning, and then we have the different interventions. So there's behavioral interventions, there's differentiated service delivery, there's clinical service package, and then we have M&E and structural intervention packages. But having a look at all these variations, I also wanted to pull out the three main things that we can see from these 15 countries. So again, there is a strong foundation. So these countries have established that they do have good management structures, and they are able to engage their sex worker communities quite well. But then having a look at where they've indicated the gaps. So there's service gaps in mental health, substance use, and the testing for viral hepatitis. So there's a need for significant expansion, and perhaps looking at integrating these services in existing health services. And then structural barriers. Again, this is something that a lot of countries seem to be struggling with. So there's inconsistent training on human rights and limited legal services that really hinder the progression in this pillar. And so there's a need for subnational coordination to try and strengthen this and ensure that there's effective implementation. And lastly, having a look at outcomes. So if you have a look at this overlay of the 15 countries for outcomes, it does appear very different to the last two that I've just showed you, in that there's a lot of gaps. And so some countries were not able to actually even opted to not complete it. But having a look at what actually makes up the outcomes, we look at the outcomes among KPs, so the indicators. And for this example specifically, we're looking at just the ones that relate to sex workers. And then there's also a function on sustainability of the program. And the other one is COVID-19 and other pandemics, so pandemic preparedness and how it relates to this programming. So again, looking at what has come out in terms of the outcomes. So this domain was actually the lowest scoring domain across the three domains. But looking here, we have data gaps. So there's a lack of comprehensive data, and this really hinders how you assess the programming. And so there's really a need for improved data systems, maybe relating back to the M&E that was scored in the implementation section. There's also a bit of mixed progress. So some health indicators do have positive results, but others, like maybe hepatitis testing and stigma reduction, they do need a bit more attention. And this is what countries have pointed out. And then sustainability concerns, which is something that has been appearing maybe across all of the pillars. But having a look here, there is a lack of long-term planning and reliance on donor funding, and that really threatens the sustainability of these programmings for sex workers. So overall, that is what the scoring and the insights that can be drawn from those 15 countries. But I also wanted to share some of the comments and qualitative information that has been shared from some of the champions that completed this. So I just pulled out 3 examples from 3 countries, and having a look here, Ghana, they completed their PSAT, and they feel that the PSAT really improved some of their HIV prevention activities. And this was enabled by the fact that the country team was able to assess and identify their gaps. And through their current HIV prevention strategies, they were able to facilitate a revision of these, and they developed tailored interventions and activities. And these activities that they developed were incorporated into their Global Fund Cycle 7. So that is how Ghana had a look at their PSAT scores and really utilized them for their funding cycle. And having a look at Zambia, they said that having completed the PSAT, they were able to establish the gaps in their programming, and the process brought various stakeholders to the table to address various gaps highlighted in the PSAT. And an example that they gave is that they were in now the process of developing a comprehensive HIV treatment guideline that focused on adolescents and KPs. So this is something that they shared last year, so I'm sure they are well ahead of finishing up that guideline and have already shared it. And the last country that shared some insights was Uganda, and they also did the PSAT that was facilitated by the SSLN, and they said there were important revelations from the PSAT completion exercise, and that they were able to see that the national HIV prevention programs maybe were focusing on limited elements and not paying attention to the others. And when they completed their next steps, they were able to identify these areas where they should direct their energy to. And so they said they fought hard to be included in the NFM4 and the COP23 grant applications. And in addition, they've submitted TA requests through development partners and through the SSLN. So that is just an overview of how countries have used the PSATs further, but I know a few speakers will dive deeper into that. But lastly, all I wanted to say about the insights that can be gathered from the PSATs is that each country is unique and they have different permutations and challenges. And so when looking at the PSAT, context matters. So looking at this example that I shared, we all know that criminalization of sex work poses a unique challenge. And so looking at programming, implementation, and scale up, we should be taking this into consideration, and how you interpret the PSAT results, having looked at the numbers and also the commentaries from the country. We can also see that there's shared challenges, but also an opportunity for tailored solutions. So there's common challenges that these countries face through budgeting and through program implementation and data collection. But the PSATs allow for this opportunity for countries to co-develop these learning agendas to address these areas that need strengthening, and they offer a tailored approach to address these challenges. And lastly, having a look at all of these results, we can now see that countries have the opportunities to learn from each other. So countries with stronger programs, and maybe even outside of the 15 in the SSLN, these can serve as models for those facing greater difficulties. And so within the SSLN, we focus on peer-to-peer learning and how we can facilitate this knowledge exchange and drive improvements in HIV prevention for sex workers across these contexts. And that's all from me. So thank you so much. And I'll hand back to Clemens.
Thank you so much, Kamogelo. This was a great overview on what is possible and what kinds of findings come out of PSAT analysis. And for those of you who'd like to familiarize, of course, with the tool in parallel, feel free to look at the tool and all the detailed questions in the tool. But what Kamogelo really showed are some of the high-level findings and actual insights you can gain on the gaps that are, on the types of gaps that are identified through PSAT analyses in those 15 countries. We now move to the next part of this session, which is a panel discussion on the use of PSATs, for which I'll hand over straight to our facilitator for this session, which is Celestine from the National Syndemic Diseases Council in Kenya. Dr. Celestine, over to you.
Thank you very much, Clemens. Good afternoon, good morning, good evening to all our participants. Thank you for joining. I think the previous speakers have laid a very good foundation for this particular session. And Kamo really has given a general overview of the PSATs. But in this session, we're going to be taking a deeper dive and hearing from specific countries on the utility of the PSATs, from prioritization of prevention, program design, implementation, all the way to financing. So we have got three esteemed speakers. I'll be introducing them shortly, but the rules of engagement for this session, we've got about 40 minutes. So each speaker is going to get 10 minutes to take us through their presentation. After that, we are going to have a Q&A session of 3 minutes. I'll kindly request our participants, as you think through your questions, if you can type them in the chat box, please do so. But if you want to raise your hand and ask, we'll also have the allowance for that, but let your questions be very, very specific and short so that we can get through as many of them as possible. So I want to introduce our first speaker, Ezine Uchendu from National Agency for the Control of AIDS in Nigeria, who will be taking us through the use of the PSAT to inform country strategies, priorities, and action plans. Over to you, Ezine. Thank you very much.
Good afternoon, good morning, colleagues, depending on where you are. I'll be sharing how we were able to use PSAT to inform country strategies, priorities, and action plans in Nigeria. Next slide. This forms the outline of my presentation. We'll look at the Nigeria country and also country champions and the state champions. We'll look at how we've been able to complete PSAT at the national level and also the subnational level. And also the subnational level. We have a PSAT map for Nigeria. Then we'll also look at the strengths and successes recorded since completion of PSAT in Nigeria, its successes, challenges, and then the next step. Next slide, please. At the national level, we first had only 7 country champions, but we were able to expand to 33 champions, ranging from representatives from different areas, including the National Agency for the Control of AIDS in Nigeria, the Ministry of Health. We have representatives from the HIV division. We have civil society organizations that are part of the country champions. We have representatives from the UN agencies. We have development partners, key population community members. For key population community members, we have champions for every key population typology. Then we also have representatives from the different networks. We have network of people living with HIV, AIDS in Nigeria. We also have the youth network of persons living with HIV and the women network as well. This is the map of Nigeria. Nigeria is a country with very large population. We have 6 zones and 36 states plus the FCT. Next slide. Completing PSAT in Nigeria. At the national level, we were able to complete PSAT covering all the different GPC pillars. So we have completed PSAT for key population program. And for key population program, we have completed PSAT for all 5 typologies that Nigeria is implementing HIV prevention programs for. We have PSAT for sex workers, men who have sex with men, people who inject drugs, transgender persons, and people in custodial and closed settings. Then we also have PSAT covering AGYW, condom program, and PrEP. Next slide. At the subnational level, we have been able to complete PSAT in 21 states out of the 36 states we have in Nigeria. And this was done with the support of our UN partners in Nigeria, UNAIDS as well as UNFPA supported this process. At this subnational level, we have completed PSAT for all five prevention pillars: key population program, HYW, condom and lubricants program, as well as PrEP. Next slide. At the subnational level, our process for completing the PSAT is as follows. We first had stakeholders meeting, and also we looked at how we can mobilize resources to be able to do this at the subnational level. And it was through this process that we were able to get our UN partners to support the completion of PSAT in 21 states in Nigeria, covering the 6 geopolitical zones we have in Nigeria. We have national PSAT assessment team composition, and we were able to select delegates to support the completion of PSAT at the subnational level. Persons selected were from different entities. We have representatives from the ministries, departments, and agencies, where we selected persons from State Ministry of Health, as well as a State Agency for the Control of AIDS in all these different states. We have NDLEA, the National Drug Control Agency, as well as the Nigeria Correctional Service. We're also part of the assessment team. We selected different representatives covering all KP typologies and also the different networks implementing HIV programs at the subnational level. We had a meeting with the NACA zonal staff. NACA has 6 zonal offices covering the 6 zones that we have in Nigeria. So the NACA zonal staff also supported us in selecting the different representatives that will be part of the completion of the PSAT at the subnational level. We had virtual meetings with critical actors and implementing partners, then training on the PSAT assessment tool. Because we were not able to go to the different states, the different 21 states to cover these assessment tools training, we had series of virtual trainings to ensure that they understand how the process is for the completion of the PSAT. Then we had a rollout exercise in different phases. For the 21 states, we didn't cover all 21 states at the same time. We rolled out in 2 different phases to cover the 21 states that have completed PSAT. The next step will include to analyze the outcome of the PSAT and then disseminate the outcome of the PSAT. Next slide. Next slide, please. So at the subnational level, we have PSAT covering all the different states that are represented on this slide. We have a total of 21 states that have completed PSAT, and this was done in 2 phases. We had a phase 1 state and then a phase 2 state for us to be able to complete PSAT in these 21 states. Next slide. This shows a map of PSAT in Nigeria. The states covered in blue are the states that we have been able to complete PSAT. Then we have states covered in red, which are states that we have not been able to complete PSAT. So like I said initially, Nigeria is a country with a very large population. Even though we have been able to do PSAT in 21 states, we still have a large number outstanding for us to complete. We have 15 states that are still outstanding, and we're making plans to cover these states as soon as possible. Next slide. Key areas of our strengths and successes that we've been able to record since the completion of PSAT in Nigeria, we have the following. We have improved coordination among key stakeholders, including the donor agencies, the implementing partners, civil society organizations, and other networks that we are working with in Nigeria. As a result of this, we have been able to restructure the National Prevention Technical Working Group meeting. We just completed the one for the second quarter just a few days ago. So the restructured NPTWG meeting is to improve meaningful participation and decision-making as we work towards acceleration of actions to reduce new infection to zero by year 2030. The PSAT was able to do that for us to be able to restructure our NPTWG meeting. We have expanded program for key populations in most states, and this has led to a strategic focus on combination prevention interventions among the key population community members. We've been able to develop a harmonized national service delivery guideline that covers all 5 key population typologies that Nigeria implements programs for. This has been finalized and disseminated, and we have partners using it in Nigeria. We have also been able to scale up our harm reduction program. We had a pilot for the needle syringe program, and we are in the process of starting up the medication-assisted treatment. The opioid substitution therapy is about starting up with the overdose management using naloxone. We are in the process of doing that. PrEP is currently being administered to discordant couples, key population community members, and also persons at risk in Nigeria. We have a robust policy and also regulation environment supporting our HIV program in Nigeria. There is strong leadership as well as coordination structure at all levels, at the national level as well as the subnational level. At the subnational levels, we have state agencies for the control of AIDS in all 36 states plus the FCT. We also have, like I said, 6 zonal offices for 6 NACA zonal offices covering all 6 zones in Nigeria. We have a total market approach in place for condom and lubricant. This has been put in place as a result of our program since completion of PSAT at the national level. Next slide. Other areas of strength and successes include the completion of the IBBIS for key population, and also the development and dissemination of different national documents. We have the AYP investment case, the HIV and PrEP communication strategy. We have a condom operational plan in place, as well as a condom quantification in place. We have also been able to develop training manuals for PrEP activities in Nigeria. We have a training manual, we have a facilitator's manual, and as well as a training manual for participants. All these were developed since we completed our PSATs and identified the need to do this. We have been able to build the capacity of women to be able to respond to issues around gender-based violence, stigma, and discrimination, and also link them to the state response teams that have been set up in different states. We have strengthened response for PLHIV champions covering different states. We have an MOU in place in NACA for National Human Rights Commission for upholding legal and human rights for key population community members. I would also like to mention that as a result of completing PSATs, we identified the need to also learn from other countries about how they've been able to address the structural issues affecting key population community members, and in May this year, we were able to go to South Africa to learn from how they have been able to improve their programs and address structural issues affecting key population from accessing HIV services in their country. On return, we have also been able to implement the learnings from that learning visit. One of the things that we have been able to do since return was to have a meeting with the law enforcement agencies as well as the key population community members to be able to discuss how we can enhance programs and ensure that key population community members have access to HIV interventions in Nigeria. We launched and disseminated the Stigma Index 2.0, and there is also an MOU in place between NACA and the Human Rights Commission. We have been able to strengthen response on human rights issues and have continued to involve Human Rights Commission as part of partners in our HIV implementation in Nigeria. Next slide.
Ezine, as you go to your next slide, you have about 2 more minutes left. Thank you.
Thank you. 2 minutes is enough, yes.
Thank you.
So also on our strengths and successes that we have recorded since completion of PSATs, we have strengthened responses for PLHIV champions, the rapid assessment to identify critical actions on removing barriers to HIV services and development of an action plan. We also did the consultative meeting with law enforcement agencies and key population community members, and even some MDA supporting activities for key population community members in Nigeria. Next slide. We have continued to record successes since completion of PSAT. PSAT has helped in generating a baseline data on HIV prevention programming at the national as well as subnational level. It has also helped in identification of gaps and priorities for prevention in Nigeria. The PSAT outcomes will also, outcomes for the few states that we have done have also supported us in providing strategic direction for prevention programming in Nigeria. We have successfully implemented key findings from the national PSAT with the support of the SSLN technical assistant supporting us in NACA. We have improved coordination and structured prevention, prevention TWG, like I earlier mentioned. Next slide. Before I talk about our challenges, one of the things that the PSAT also helped us to do was to identify the need for knowledge sharing. And as a result of that, we were able to conduct the 2024 Nigeria Prevention Conference that happened in May, where partners from different states were able to come and share their knowledge on HIV prevention interventions at the subnational level. We also had international partners that were also part of the conference. For our challenges, funding is still a challenge. We have not been able to complete PSAT in all 36 states due to inadequate funding to do this. Capacity gap at the subnational level was also identified during the completion of the PSAT. There is need to build capacity at the subnational level. The short time frame for completion of PSAT was identified, and we have agreed that for subsequent PSAT completion, instead of 3 days, we'll now have 4 days to complete it at the subnational level. Next slide. For our next steps, we'll complete PSAT in their standing states and then analyze the outcomes from the completed PSAT. Follow-up on the states, on the outcomes of the PSATs will be done as soon as we complete all the PSATs. And we are hoping that in another 2 years, we should be able to have a PSAT Lite to review what we have done in the 2 years. Next slide. Next. Okay, thank you for your attention. This was the last champions meeting that held a few weeks back. Our champions meeting happen every quarter, and we have had 2 champions meetings this year. Thank you for your attention. Over.
Thank you very much, Ezine. Great presentation. A lot of positive feedback on the chat. Somebody has given Nigeria 21 gun salute. A lot of good comments coming your way. So well done. I think the progress that you have made is very impressive. So a lot of them are congratulatory messages. But I think in the interest of time, I'm just going to zero in on 2 issues. There's a question from Heather around how the PSATs are different, or how you're finding them different from the traditional reviews around HIV prevention that we used to do. And there's another question that is asking, is there a specific PSAT for national level and for subnational level? And maybe how I would like you to share this is, you mentioned that you have done the PSATs at subnational level in 21 out of 36 states. How were you able to do that? How are you able to synthesize the findings of all those PSATs and cohesively moving at national level? Because I would imagine that the epidemics are different in the 21 states. So over to you. Ezine?
Yes, thank you.
Where had you gone? You know, we saw you standing from the chair. Okay, go ahead. You had the question?
Yes, I did.
Okay.
Thank you.
So you have 1 minute. Yeah, thank you.
Okay, so we have PSATs that we used for the national level, which we adapted to suit the realities at the subnational level. So that was what we did. Then there's another question on how we were able to complete PSAT in all the states. Like I earlier mentioned, we had different meetings to discuss about different planning meetings before we set out to do PSAT at the state level. So during those meetings, we were able to discuss with our country champions and identify who goes to what state. We also had trainings ahead of our visit to the state. So during those trainings, we were able to bring them up to speed to know what to expect during the completion of the PSAT. At the state level, we selected state champions for each state. And the people that came to complete the PSAT are also persons implementing programs in the state. We selected IPs working in particular states where we visited to complete the PSAT, as well as the state MDAs, the ministries, departments, and agencies supporting HIV prevention, treatment, and care programs at the state level. For each state, we have state agency for the control of AIDS. And selection of the state agency for the control of AIDS in that state also helped us to identify the most relevant people that will provide the information we need to complete the PSAT. Thank you.
So thank you very much, Ezine. I think what you've told us is that you customized the tool that you had at national level for use at subnational level. But most important, Nigeria has got in each state agencies that champion HIV prevention, and those are the ones that actually give you the champions that now you are working with to realize the gains that you want to achieve. So thank you very much for teaching us about innovation and also how to basically enhance coordination at national and subnational level. So excellent job. We're quickly going to move into the next presentation.
Thank you.
Thank you. So keep looking out in the chat box, Ezine. in case any questions come, you can type the responses there. All right.
Okay, I will.
Okay.
I'll look at it now. Thank you.
Thank you very much. So now we're going to have Dr. Daniel Biamukama, my friend from Uganda, who will be taking us through PSAT at the subnational level and what their experience has been. Dr. Daniel, welcome.
I will request. Okay, thank you. Thank you for sharing my. So we can go to the next slide. So I am Daniel Biamukama. I work with the Uganda AIDS Commission, and I'm pleased to be your facilitator this afternoon in Uganda. So in my presentation, I will highlight our journey in the SSLN, and briefly the GPC. I will introduce you how we initiated the PSAT process from national to subnational level. I had people asking questions about national, subnational PSATs. And I will tell you what we have been able to do with the PSATs findings. And I will shed the light on the impact of the subnational PSATs on decision making and progress. Next slide, please. So Uganda is one of the initial countries. Members of the GPC were there when the GPC was formed, and we were among the 10 initial SSLN supported countries. We commenced our engagement in 2020. For our initial engagement, like all of you are aware, the support was focused on key population programming, mainly sex workers and men who have sex with men, and condom programming. And Uganda was supported to complete PSATs in for both of those programs, which would facilitate a baseline country-led self-assessment of the national prevention program, which informed our action plans, technical assistance plans, and capacity building needs. Next. So we started on the PSAT. So the earlier part of 2020, there were initial introductory processes, but the real engaging gear to work on the PSATs was in July 2020, when the SSLN team introduced the country champions to the PSAT. So the country champions were first trained, and after being trained, we were then able to roll out the PSAT. And our process involves, so for our coordination mechanism, we have what we call a key population steering committee, which is a subset of the National Multisectoral HIV Prevention Committee. So the key populations is like a subcommittee. So the first team that engaged with the PSAT after the national champions were the key population steering committee. We took them through the process, though the focus was on MSM and sex work at the time. We preferred to work on all the 5 pillars, on all the 5 elements, the 5 groups of key populations. And after the National KP Steering Committee completed and attained a consensus on what our score are, what our program performance looks like, we took it to the bigger multisectoral National HIV Prevention Committee, which has most of the key population steering committee has a representation of key population communities, implementing partners who are serving key populations, civil society, in addition to public sector. And so is the National Multisectoral HIV Prevention Committee, but it is wider and has a wider representation. So once our PSAT was validated, we had the PSAT. We attained consensus and were able to share with the SSLN, who helped us with developing a narrative report. A narrative report that identifies our strengths, our gaps in program implementation, and the next step, next slide, and to develop a learning and action plan. So our PSAT that was validated in the country was shared with the SSLN. They helped us analyze it, summarized it, and presented in a visual report format, which is not attached, but it's on our website. Through country discussions facilitated by SSLN, the country team was able to identify the strength of the national program that would be shared with other countries in the running network, as well as prioritize 48 needs and draft comprehensive action plans. So guided by the plans we have developed, the country's champions engaged in a number of learning activities which have really revolutionized our program, and I will not go into detail, but we have, for example, visited Kenya to run their methadone, their opioid substitution therapy program, which is at a wider scale for us. We only had started the program. We're struggling actually to start one at the Mental Referral Hospital, but we ran from Kenya, but they can do outreaches. And now those lessons learned informed our grant applications for the Global Fund grant application, even COP 23, so that we're able now, we're planning to scale up some of the new things we learned from the exchange program. So next, please. And of course, what we learned through the PSAT process. For example, as I've said, as much as the initial engagement was focused on MSM and sex workers, we insisted and worked on all the 5 groups. We discovered our program had nothing. We almost scored 0 on the transgender program. And so our technical assistance needs and requests were focused on strengthening some of those areas. And our strategic documents were silent on some of these population groups. But fortunately, at that time, we're working on our new national strategic plan, and we made sure that it's well aligned to the 5 pillars, and we could easily articulate and defend the 5 pillars of prevention, and the 5 population groups which form the key population category. So at national level, with our PSAT and the PSAT reports, and having used it for various processes like technical assistance needs, reviewing the midterm report, midterm national strategic plan, midterm review, which informed the second phase of the priority action plan, which emphasizes the findings we established on the PSAT, but we were changed by the PSAT. The PSAT is a very important tool. Like the previous speakers presented, it is a capacity building tool. I often make a joke here that there is no university in Uganda, whether a medical school or a school of public health, even a sociology school, that teaches HIV prevention as a module. All of us who are heads of prevention were there because maybe you attended public health school or medical school or sociology school, but there's no module called HIV prevention. So we were experts, but really we are not real experts. But the PSAT process and SSLN engagements, the capacity building that came out of assessment, the honest assessment, has really helped us sharpen into real HIV prevention experts. So from the several lessons that we learned during the PSAT process at the national level, for us in Uganda, we are determined to conduct PSATs at the decentralized level. This was important because our government, the decentralized government system we have, the districts are an independent planning and implementation unit. Actually, the leading planning and implementation unit. So if they are not engaged, things stay at national level, but they don't get to the decentralized level. And this is what we found, because early in 2023, our first subnational PSAT was on adolescent girls and young women. Our conversation with the subnational stakeholders, we were convinced that the rich national conversation we have does not really translate purely to decentralized level. Some of the scores we had at national level for the adolescent girls and young women were not reflected at subnational level. In a sense, the rubber doesn't touch the tarmac. We have so much rich conversation at national level, but there's a bottleneck somewhere. So we were keen to go to the centralized level because the key planning implementation unit, and what we discovered was so revealing and has empowered us to talk to stakeholders to give us resources actually to go to all regions. So at subnational level, we combine a few districts, select leaders. If we are addressing the adolescent girls and young women PSAT, for example, we choose key stakeholders who are key, including public sector, civil society, implementing partner, and donor organizations to participate. Public sector, ensuring including education, health, and all the relevant sectors in the AGYW. We do the same for the KP population programming and PrEP. So to have a richer conversation, and we have a sub-regional meeting where we have 7 districts into one group. The unique situation in Uganda is that each sub-region has one implementing partner. The main source of funding for most of our programs, especially adolescent girls and young women, and KP programming, is donor funding. And the donors are structured that each region has one coordinating donor partner or implementing partner. And so is it to convene a sub-region, go through the same tool, have a conversation and assess the region, produce a report, because the main actor, the main implementer is going to be the donor partner who is in charge of the whole region anyway. So we have had such a conversation in several regions. We have so far, so we did the adolescent girl and young women, but as you are aware, we had a challenge with the neuro, which was an homosexuality law. So it slowed the momentum in starting with the key operation PSAT implementation at subnational level, which was a high priority for most of the donor agencies which support these processes.
Sir Daniel.
But with time.
Sir Daniel?
Yes, hello?
You have 1 minute left. Huh?
There's one?
1 minute left, please. Thank you.
I am almost finishing, of course. So with support, we have been able to implement these PSATs in 4 sub-regions. 1 sub-region, we implemented the AGYW. The 3 sub-regions, we have implemented KP programming and PrEP PSATs combined. What we realize is that there are few words which are not really contextually appropriate for the subnational level, but these can be explained and contextualized for the audience. And what we anticipated, we find is a big divide between the scores at national level and subnational level, implying there's a bottleneck, and we're hopeful. So we have not done so much of the analysis of the KP, PSAT, and PrEP PSAT at subnational level, because as says, we are delayed by the law, but recently with the clarifications on what the law implies, we are regaining momentum. So we have already done 3, focusing on PrEP PSAT, so they will soon be analyzed, and we hope like the adolescent girl and young women, they will inform restructuring of planning. When the districts are developing their priority plans, we develop these priority plans, they will inform these processes which are already underway. And that's right. So thank you. In summary, subnational PSAT processes can be done. They have the same benefits. They reveal the assumption that what we are doing at national level is not actually what happened at subnational level, calling for greater subnational engagement and also refocusing and strategizing. Thank you so much for listening to me.
Thank you so much, Dr. Daniel, for your excellent presentation. Again, highlighting the importance of looking at what is happening at the subnational level. And I think also bringing out innovation from Uganda around customizing and even looking at the languaging in the PSAT and seeing how useful it is at the subnational level. There was a question for you in the chat, and I think you have maybe briefly talked about it, asking how you navigated the KP PSAT and the current legal environment, but I think you have talked about it. If you do wish to add more detail, you could do that, but I think you have said that it has slowed down a little bit, but you're now more or less getting on track. But I wanted to ask something around, you said that the scores that you had at national level were not translating to what you are seeing at subnational. So do you have any specific reasons for that from the Uganda experience? Was it an issue of technical capacity, knowledge of how to implement prevention programs, or is it an issue of funding? Maybe just for us to get a better picture of why you are seeing disparities at subnational level. Thank you.
Yes, we think the main challenge is capacity. That the caliber of the health worker at the district level is often multitasking, and there has been no capacity building for this health worker. And of course, the second one is resources. So the resources to translate policy into practice, We may have nice policies at national level, our discussions are rich and our plans are rich, but what actually gets implemented is dependent on the finances. So I would say both capacity and finances we are discussed as a key player, a key determinant of why there appears to be a bottleneck, but the bottleneck is real.
Okay, thank you very much, Dr. Daniel. Again, speaking to us, looking at not just good program design, but thinking around not only service delivery, but who are the service providers and what we need, and working within our existing context. So keep checking in the chat box, Ezine and Dr. Daniel, for any questions, and please respond as they come. We want to quickly move to our last presenter for the session, Dr. Raymond Buke, my other friend from Zimbabwe. Nak, who's going to be taking us through how they use the PSAT to inform Global Fund application, or what their experience was like. Over to you, Dr. Raymond.
Well, thank you very much, Celestine, for chairing and facilitating this session, and also just recognize my other colleagues, Ezine and Daniel. We have made this last part of the presentation much lighter, as they have covered most of the essential issues around PSATs. And from Zimbabwe, we are sharing briefly our experience in using PSAT to inform global fund application processes. So next slide. So in terms of the outline of my presentation, the overview, it's just the introduction, our Zimbabwe PSAT overview, just briefly the summary of the results, and then how we used those results to influence global fund investments. And then I will conclude, and I hope I will be on time. Next slide. So in terms of the overview, just the next slide. Like my colleagues, so let's move on to the next slide. So as my colleagues have already presented, we are one of the early countries to be part of the SSLN in 2020. And we conducted a number of PSATs for the different programs which are on the far right. And these are champion-led assessments. They were led by the champions from the different programs. And in terms of our composition, I think I won't want to repeat. I think our composition in terms of champions looks exactly like the other countries. And then from the scores that we saw, the lowest was around people who use and injecting drugs. And then the highest was around VMMC and condom use. So basically what PSAS did for us was to foster an open and honest national dialogue on HIV prevention progress, our challenges and our opportunities for improvement. And it was obviously a catalyst for action. What that did was that it helped us as a country to identify our strengths, our weaknesses, and then helped us to drive targeted action and program adjustments. At the bottom there is just a quotation from one of the key informants in terms of how they benefited from the PSAT process. Next slide. This is just in brief an overview of the KP findings in 2022, which was via the PSAT Lite. And you will note that we did it across all the KP, the 5 KP groups: sex workers, MSM, transgender programs, we noted that for prisoners and those who use injecting drugs, we need to strengthen because the scores were very low, 1.3 and 1.4. Next slide. So I think my my main focus is really on how we used the PSATs to inform Global Fund investments. And just move to the next slide. So yeah, so Zimbabwe was applied for its last for the 2024 to 2026 GC7 grant in 2023, and that's why probably I put in that slide on the findings in the KP, particularly for those who inject and who use and inject drugs. And I think all of us are familiar with the Global Fund processes in terms of what goes in the context, the funding request itself, the implementation arrangements, and then, of course, issues around sustainability, co-financing, and transition, etc. And at the bottom, it's just showing where the PSAT, the tools were useful in all these processes. Basically, we had to do a self-assessment, a rapid self-assessment. And one of the challenges, of course, that we always find when we are developing Global Fund processes is proposals, is the need to rely on evidence. And what is it that you used to inform what you are saying you want to target and prioritize? And so that was one of the key issues that we used the PSAT for. And then issues around the resource allocation, resource needs, capacity needs, technical assistance needs. I think these are also areas that are focused on as we are developing the GC7. And we spent we used quite a lot of the information that we got from the self-assessment tools to inform that process. And then, of course, benchmarking, monitoring progress for comprehensive HIV prevention. And then because the resources are never enough, when we got our envelope, we had to prioritize. And also, in certain cases, also push and advocate for certain key interventions that did not seem to have resources. You will note that for Zimbabwe, I think one of our GC7 proposal is probably one of the heaviest commoditized grants. So a lot of procurements in terms of medicines, a lot of procurements for lab support. And so there's very limited resources for things like AGYW, for KP, for PrEP, and so on and so forth. And so it's really a question of being able to make a case so that whatever you require is prioritized within the Global Fund investments, particularly for HIV prevention. Next slide. So during the stakeholder collaboration and consultation, and also in terms of just self-reflection on progress, these are some of the things that we noted. These things include that Zimbabwe generally has a declining HIV prevalence, and also reducing rates of new infections. Our treatment cascade has improved. In fact, we were very close to 95, which we have since achieved even at the beginning of the grant. We had noted also using the PSAT, the dramatic scale-up of PrEP. We also noted that using the PSAT, we had gaps in reliable data for KP, for adolescent girls, and also for children. And we also needed to update our population size estimates for female sex workers to better inform the targeting. And then this was the first formative sort of assessment that we had on people who use and injecting drugs, which was also part of the data that we used. And then we also noted persistent structural barriers to the HIV response. What we noted, of course, was that we were, on one side, there was a celebration in terms of government increasing the legal age of sexual consent from 16 to 18. So you could be, previously you could be a mother, but you were not able to vote. But we also noted that there were challenges with those, with that particular gain, because then access to services for those that are below the age of 18 became restricted. We also noted that HIV-related stigma was rising, and particularly high amongst key populations. And then we also decriminalized HIV, willful transmission of HIV as one of the key issues that we noted as we were doing our PSAT. And of course, this also then moves me to the next slide, where we also then said from the assessments that we had done, we also needed to look at our national documents. We had to update our NSP to align it with the findings and also the application process for the Global Fund, which is GC7. But also other documents that were there, our operational and service delivery manual, they needed to be updated. As I indicated, our NSP, we had to have an addendum to be able to have an M&E plan that covers us to the end of the grant in terms of its life cycle. Our original one was ending in 2025, so we developed an addendum to include one more year for the year 2026. We generated new forms of PrEP. The new forms of PrEP had been approved actually in the country in 2021, and we also needed to see how best those can be included in our application. Oral PrEP, the issues around triple elimination, our new national drug master plan, as well as our HIV prevention operational plan, which is currently under development. Next slide. Next slide. So
Raymond,
just some
Raymond. Sorry, Raymond.
Yes.
Yeah, one more minute, please. Thank you.
1 more minute. Okay, thank you very much.
You.
Obviously, I will not go through all the slides. The slides will be shared. For adolescent girls and young women, based on what we noted in the PSAT, we actually scaled up some areas as well as introduced new areas based on the gaps that we had noted. Next slide. I think this is the same with sex workers. For sex workers, you will note that we did not scale down any of our programs, but we actually scaled up, and we also introduced new programs based on the findings from the PSAT. Next slide. And for men who have sex with men, there were some programs that were scaled down, but we also scaled up some programs and also introduced 4 new programs in the new grant based on what we had found from the PSAT. And then for those who inject drugs, next slide. This was all of it. You will note that this was all completely new. We didn't have any programs for those who use and inject drugs, and this was part of the successes in terms of using the PSATs. And then transgender people. Next slide. We did scale down 1 activity, scaled up 3, and we introduced about 5-6 new programs under Global Fund. So again, a significant shift in terms of how we do business and convincing and leveraging on the investments from the Global Fund. And then lastly, the prevention with among other vulnerable populations. I think this one we scaled up 3 or 4 areas. And I think lastly, because I had a minute, the insights, which is the last slide, actually a conclusion slide. So the insights and evidence gathered through PSATs can be utilized to strengthen the investment case for revitalizing funding for a robust HIV prevention response in a country. I thank you.
Thank you so much, Dr. Raymond. Excellent, excellent presentation. And I think in addition to what the previous presenters had said, the fact that you have highlighted that the PSATs made Zimbabwe more aware of forgotten, or should I say underserved populations, like the persons who inject or use drugs. And that is now a new and a robust program is really impressive to see. The other very great thing from Zimbabwe is that you have demonstrated the progressive nature of your programs, that there are services that you will upon based on what the PSATs have told you. So thank you very much for highlighting that. I don't see any specific question in the thank you. Our 3 participants to engage with this. Look at the PSATs at national, but also at subnational level, because epidemics are vastly different across regions in country. Service delivery platforms also is an issue that has come up, and how the PSATs now are bringing that to the fore, even as countries do their HIV prevention programs. At the most important, the PSATs have actually created a transparent and accountable environment in country, where now all stakeholders are coming and sitting on the table and determining is how do we use the donors, but also from our government. So thank you very much for an engaging session, and I want to hand it back to Clemens.
Thank you so much, Dr. Celestine. And from here, we actually move into further reflections on PSATs beyond the data and the data collection process, and really looking at how they have been building trust, how they have been leading to greater cohesion at the country level. And we have 2 country experiences. And we start with Jean-Claude Tongo-Elongo from the Republic of Congo with some key reflections on the use of the PSAT in the Republic of Congo. So over to you, Jean-Claude Tongo.
Merci beaucoup de m'avoir accordé la parole. Je remercie le SSLN pour cette invitation. Je partagerai l'expérience de la République du Congo. On peut aller prochaine diapositive, s'il vous plaît. Donc, ma présentation portera sur le voyage de la République du Congo au sein de SSLN. Ensuite, je vais aborder le processus d'élaboration du PSAT et démontrer comment cela a renforcé la confiance et la cohésion grâce à un dialogue ouvert. Et je chuterai par des idées à l'action, donc démontrer comment cela a favorisé des changements. Diapo. Ce qu'il faut savoir est que la République du Congo a intégré le SSLN en janvier 2023 et a 4 piliers pour le SSLN. Il y a adolescents et jeunes femmes, excusez-moi, prophylaxie pré-exposition, donc la PrEP, il y a le préservatif et les populations clés. Et pour les populations clés, il y a particulièrement les travailleuses de sexe et les hommes ayant des rapports sexuels avec d'autres hommes. Et les organisations, plutôt la composition des champions au niveau national, parce qu'au Congo, il y a 32 champions. Il y a issus du gouvernement, des organisations de la société civile, les agences du système des Nations Unies et les membres de communautés. Donc, chaque champion les champions ont dirigé la validation de l'outil PSAT, donc l'outil d'auto-évaluation pour la présentation, pour chaque pilier. Donc, c'est ce qui s'est fait au Congo. Diapo. Merci. Dans le cadre de l'outil PSAT, donc d'auto-évaluation, l'outil d'auto-évaluation pour la prévention, c'est vraiment un processus qui a été participative, un dialogue honnête avec les différentes parties prenantes, ce qui a permis à ce qu'il y ait vraiment de dialogue. Donc, vous allez voir qu'il y a sur base de tout ce qui a été fait, il y a des scores. Donc, vous allez voir le score de 2,9 pour le préservatif. Il y a aussi les femmes professionnelles de sexe à 2,7, les hommes ayant des rapports sexuels avec d'autres hommes à 2,5. Ce qu'il faut savoir, parmi les piliers que le Congo a mis en place pour le SSLN en République au niveau du pays, les populations clés, le pilier population clé a été sous-performant. Donc, il y a les travailleuses de sexe et aussi les hommes ayant des rapports sexuels avec d'autres hommes. Donc, cela a été sur le leadership, la coordination, les financements, le suivi, évaluation, le paquet d'interventions structurelles et aussi l'intervention clinique et la durabilité. Donc, ce sont ces actions-là, quand le PSAT a été fait, le pilier population clé a été vraiment sous-performant quand le travail a été fait, ce qui a permis à ce qu'il y ait des actions concrètes. Diapo. OK. Ce qu'il faut savoir, au niveau global, il y a eu un score de 6,1 sur 10 pour les champions au niveau national. Mais cette enquête a aussi montré un faible niveau de compréhension des données probantes au niveau du pays. Il faut aussi souligner également la nécessité d'améliorer la coordination, l'appui technique, la cohésion entre les acteurs de la prévention du pays au niveau du pays. Donc, ce processus a vraiment permis de déceler un peu ces faiblesses, mais aussi certains problèmes parce que cela a été la première fois qu'un tel exercice soit fait plurisectoriel avec différents acteurs de lutte contre le sida, comme on vient de le dire précédemment. Diapo. Diapo, s'il vous plaît. OK. Maintenant, pour renforcer la confiance et la cohésion grâce à un dialogue ouvert, ce qu'il faut savoir, c'est que les résultats de cet outil comme on a dit, le PSAT, ont guidé l'élaboration et la mise en œuvre conjointe des programmes d'apprentissage, des plans d'action, des plans d'assistance technique. Ce qu'il faut savoir, dans le cadre de SSLN, la République du Congo a pris part à 3 webinaires sur des jeunes, adolescentes et jeunes, populations clés, et puis sur le préservatif. Et il y a aussi 3 ateliers en personne que la République du Congo a pu prendre part. Il y a au niveau de Cape Town sur la panne prévention, sur la PrEP au Ghana, mais aussi un atelier au Nigeria, un atelier régional au niveau du Nigeria en octobre 2023. Diapo, s'il vous plaît. Ce qu'il faut savoir, c'est que l'exercice de PSAT a permis à ce que la République du Congo bénéficie d'une assistance technique parce que en 2023, le Congo a intégré le SSLN en 2023. Il y a eu tout ce processus d'analyse, de validation de ces PSAT pilier par pilier, et globalement, cela a permis d'identifier des besoins principaux, notamment l'assistance technique. Et aujourd'hui, le Congo bénéficie d'une assistance technique à long terme pour renforcer la coordination et la programmation de la prévention du VIH en se concentrant sur les populations clés. Comme on a dit précédemment, le pilier population clé était moins performant et grâce au programme SSLN, il y a l'assistance technique qui est en cours actuellement, qui a pour objectif d'assurer une riposte de prévention, améliorer le suivi, l'évaluation et la gestion des données des programmes, mais aussi soutenir le développement et la fourniture d'assistance technique à court terme. Donc, grâce au PSAT qui avait été fait, grâce aux faiblesses qui avaient été relevées, aujourd'hui, le Congo bénéficie d'une assistance technique à long terme sur la prévention. Diapo, s'il vous plaît. OK. Au niveau de la République du Congo, il y a aujourd'hui, grâce au PSAT qui a été fait, il y a la gestion et la coordination du programme national qui sont aujourd'hui guidés par le nouveau plan d'action. Donc, il y a un plan d'action qui a été élaboré grâce notamment à tout ce processus-là. Et la République du Congo a officiellement rejoint le GPC, le programme mondial de la prévention, en 2024. Et il y a aussi un autre point, c'est qu'au niveau du Congo, il y a l'utilisation de l'art pour faire la promotion des droits humains, mais aussi la lutte contre les violences et les discriminations basées sur l'orientation sexuelle et l'identité de genre, faire de la sensibilisation en utilisant la rumba congolaise, parce que la rumba congolaise a été inscrite au patrimoine immatériel de l'UNESCO. Et dans le cadre de la sensibilisation des masses, la rumba est aussi utilisée pour pouvoir sensibiliser tel qu'il y a une chanson qui a été produite par l'association Cœur Arc-en-Ciel qui fait la promotion d'Indétectable égal intransmissible, mais aussi le film Michel qui a été produit, un film fiction basé sur une histoire vraie passée au Congo d'un jeune homosexuel pour pouvoir sensibiliser les Congolais, mais aussi les francophones d'une manière générale et les anglophones parce qu'il y a aussi les sous-titrages qui ont été intégrés contre les violences et les discriminations basées sur l'orientation sexuelle et l'identité de genre en République du Congo. Je pense que c'est la dernière diapositive, si je ne me trompe pas. OK. Merci beaucoup à toutes et à tous et merci à l'organisation.
Merci à vous, Jean-Claude Pongo. Was a wonderful presentation on the experiences in the Republic of Congo on the PSAT and the context. We have another presentation now, and we can go straight to the presentation from South Sudan here, sharing similar reflections on the context in South Sudan. So over to Peter Garangore from South Sudan for sharing these reflections on the PSAT process beyond the data, looking at building trust and cohesion in the country.
Thank you so much, and good afternoon, good evening, good morning, wherever you might have tuned in. And I'm Peter Grang, the HIV prevention consultant for South Sudan. And so this presentation will really focus on the key reflection on how, and also on how the PSAT has built the trust and cohesion among the different stakeholders that are implementing HIV prevention services in the country. And so this slide is giving us a brief background on when we joined the SSLN and what happens, immediately as the country joined. We joined the SSLN in November 2022, and immediately we opted, to have a PSAT being done for 5 pillars. Key to note from here is that under key population, we specifically did female sex workers sub-pillar, and based on the context of the country by then. And a sub-technical working group actually nominated 40 country champions that were a representation from government, national and international NGOs, UN agencies, civil society organizations, and community members. These champions were actually nominated to lead and validate the prevention self-assessment tool for all the 5 pillars in December 2022. The in-person meeting was done, and each of the champions were actually subjected to signed terms of reference. And then as a country, we also had a baseline capability and effectiveness survey. You will actually see in the next slide what the results were. And then as a country, we formally joined the GPC in March 2023. Next slide. This slide tells us the results of the scores of our PSAT that we did in the 5 pillars. And the scores range from 1.7 under a condom pillar to 2.6. And this was out of 5. And as you look at our right-hand side, you could see that the country champions had opportunity to do capability and effectiveness survey that had a score of 5.6 out of 10 as a baseline in 2022. And the capability and effectiveness survey was really key to understand the perspective of the country champions on HIV prevention programming in terms of trying to function together as a team. And the key results from our PSAT were weakness in program management, stakeholder engagement and coordination, as well as monitoring and evaluation. And I just pull out a statement from capability and effectiveness survey that we managed to, to get in 2022, that this is a statement from one of the respondents. Limited feedback loops with other stakeholders, lack of consensus across stakeholders. Vertical programming means that the stakeholders are not integrated. That was one of the respondents. Next slide. As a result of PSAT finding, as a country, we were able to co-develop and implement learning agendas, action points, and technical assistance. And as a result of PSAT finding, as a country, we were able to benefit from wide range of knowledge exchange activities that were delivered both in person and actually virtually. And as a country, we attended 5 AGY, 5 KPs, and 5 condoms webinars. We also had an opportunity to host Link and Learn on learner pregnancies, because as a country, we have very strong policies when it comes to the learner pregnancy policy in the country. And so those who got pregnant when they are teenagers are able to continue with their schools, without being prevented from continuing. So that was a good thing. And as a country, we had a hosting on that. We had also in-person workshops that we attended, a number of them, and participated in 5, in total 5 key population, 3 AGYW, 1 condom, and 1 PrEP Link and Learn sessions. Next slide. So this slide is really telling us how, as a country, we utilize the PSAT finding to seek technical assistance from SSLN to address the gaps that we identified. And as a result of PSAT, finding, we managed to secure a recruitment of national consultant to strengthen the program implementation, stakeholder engagement, and monitoring. And also, we were able to support a short-term assistant to incorporate HIV prevention indicators into national illness management information system, because one of the findings was a big gap in data management, and most of the data sits at partners level. So currently we have secured a support from SSLN to ensure that the HIV prevention indicators are integrated into DHIS2. At the advanced stage, we are also secured a technical assistant to support the revision of national HIV prevention strategies that will be aligned to the global HIV/AIDS prevention strategy 2025. And if you look here you will notice that we were able to do a follow-up effectiveness survey, and you could see the changes that actually happens from 2022 baseline to follow-up survey that we did among the champions. And the country's champions demonstrated significant increase in HIV prevention-related capability and effectiveness. And you could see a shift from the baseline of 5.6 in 2022 to 7.4 in 2024. This is how far the PSAT and a follow-up of action plan has actually managed. Given given the country ability to go around and then increase our capability and effectiveness survey to this level. Next slide. This slide talks about how, as a country, we are seeing the value of PSAT in enhancing HIV/AIDS prevention in several ways. One of which is that during the Grant Cycle 7 application that started in 2023, we were able to incorporate HIV program stewardship into the Grant Cycle 7, which was actually funded. And also currently, the tools that were lacking, especially the guidelines and policies on voluntarily medical male circumcision, the key and vulnerable population guidelines are currently developed and validated as a result of the usefulness of PSAT. We also have plans that are currently underway to revise the national condoms strategy, pre-exposure prophylaxis, and adolescent girls and young women strategies. And there are calls to ensure that we have a nationwide integrated biological and behavioral surveillance, issues of having CAP surveys across the country. And we are enhancing knowledge sharing through participation in Learn and Learn sessions. And you could see a statement from one of the respondents as we did a follow-up survey that and I quote, the TWG now brings in almost all the stakeholders to discuss national concerns on HIV prevention. That was a South Sudan respondent, and that statement was extracted from Capability and Effectiveness Survey. Next slide. Key learnings we have gained from PSAT implementation is that the PSAT helps us to identify critical program weaknesses and strengthen to inform targeted interventions and resource allocation. Also developing tailored national HIV prevention action plans based on identified needs, and also strengthening funding requests and ensuring efficient use of resources, facilitating cross-country learning and collaboration, and enabling ongoing monitoring, evaluation, and adaptation of HIV prevention programs. These are actually emphasized on the feeling of the country champions. And again, one of the statements that we were able to extract from Capability and Effectiveness Survey was that one of the respondents said, "We have noticed some improvements in stakeholders' mobilization and engagement. This needs continuous engagement for sustainability." Next slide. Thank you so much for the audience.
Thank you. Thank you so much, Peter, for this great presentation and the reflections. We are reaching, or we close to the end of this session of today. I understand there is still a survey. So over to the SSLN team for a few quick survey poll questions. So if you could please answer those just now. I don't know, Karabo, should we wait for the answers to come in for a moment? I think we'll give you one moment to at least get started, but considering the time, we also need to wind up. Great. Okay, so we will leave the slide with the poll question, the panel with the poll question up for one more moment. Well, thanks again to all the speakers for these great contributions and wonderful learnings from countries. We have seen so many different applications of the PSATs and so many different types of lessons. Just to mention, I mean, one from Nigeria, using this at the subnational level, which was really innovative at such a large scale, so many different places having done this and, systematically done, of course, in collaboration with the Global Prevention Coalition, acceleration team and stewardship support. So great to also see those synergies and collaborations between different but complementary global initiative. And of course, we know in Nigeria also work ongoing on an e-learning module that can perhaps then also translate some of these findings into real capacity development activities. And that brings me to another thought, another point I've picked up from Daniel in Uganda, who said, we are all not, people who studied HIV prevention in university. There is no HIV prevention module in university. And that's not just true for Uganda. That's, of course, a global reality that HIV prevention is extremely knowledge intensive and skills intensive. So both knowledge and skills, and it brings together so many different types of knowledge and skills: epidemiology, communication, service delivery, outreach, supply chain systems, human rights-based approaches. So really many elements need to be brought together in prevention. And the PSAT is actually one of the tools that consolidates a lot of this knowledge, and thereby is also actually, as Daniel rightly observed, a capacity development tool where we can actually use a very systematic framework across all those different dimensions of programming and take stock of our progress made. And as the Zimbabwe presentation has shown, it can be relevant, of course, to the global fund application process. And there was discussion in the chat, and we received this question very often: what's the difference between PSATs and the scorecards and other tools? And Heather Marie, in her overview slide, that one overview slide, explained that so clearly. The prevention scorecard is really looking at the higher level coverage indicators across the 5 pillars, the outcomes like condom use of PrEP, male circumcision uptake, and then finally the impact in terms of effects on HIV incidence. So the scorecards are really sort of a high-level outcome tool, and in a global fund process, to bring it back to the Zimbabwe experience, really is sort of more relevant for prioritization, looking at the big picture, identifying high-level gaps. And then the PSAT comes in for the very detailed and granular assessment of what to do about it and how to address those high-level gaps. And perhaps one thing to take forward and to encourage is to always look at scorecards and PSATs alongside and see, in some areas we might be doing fairly okay on some of the program management issues, but not yet there on the outcomes. But in some areas where we have fairly good outcomes, we can still improve and actually fine tune. And that's what the PSAT brings us here as well. So I won't go further into the details which were shown so well. Just as an encouragement, let's continue using, let's continue sharing, let's bring it together with other tools, and really then take, most importantly, these findings forward and have as much time as we spend on actually doing the assessment, spend on the utilization of the data for programming, on the problem solving that comes out of these assessments and discussions. And that's really where we will then make the difference and can come back maybe in a year, or maybe in some cases it's already after 3 months to assess some elements that we've addressed again and take stock of the improvements made. So great session. Thanks to everyone. Of course, most importantly, also to our South to South Learning Network team who have organized today's session tool as well, and of course all the presenters, facilitators, Dr. Celestine, thank you. And of course, with that, unless there's any final logistical remarks from the SSLN team, we can close from here. And you have here again links and further resources to dig deeper. Thanks so much and have a wonderful afternoon or evening.